All right, we're going to give it a few more seconds before I begin. While people are joining. All right, hello everyone, and thanks for joining Risky Business, Navigating CMS HCC Changes for 2025. My name is Jordan Leibovitz. I'm part of the marketing team here at IMO Health. I'm happy to announce that this webinar has been approved for CEUs via HEMA. So the recording of this and the certificate of attendance will be sent to you via email later this week. If you have any questions throughout this webinar, put them in that question section on the bottom of your webinar console. And as our speakers wrap up, we'll do some Q&A. So today we have our lovely speakers, June Bronnert. She is our SVP of Global Clinical Services, and Dr. Stephen Rube. He is our Chief Clinical Officer here at IMO Health. So with all of this being said, I'm going to go pass it on over to Dr. Rube.
Thank you, Jordan. Well, thank you, everybody, for joining us today. June is certainly going to be the headliner for this act this afternoon. I'm just here to give a little bit of background, a little bit of color, kind of set the table for this discussion around hierarchical condition categories, a term that I find very difficult to say, so it's been abbreviated to HCCs in general. So who are we? Just as a quick refresher, IMO Health. We are not new to this game. We just celebrated our 30th birthday last year. IMO Health is the provider of clinical interface terminology to most of the electronic health records in the United States and across the English-speaking world where they practice medicine in English. We provide clinically friendly terms, and those terms are then mapped by our mapping and coding teams to the administrative and the standard code sets. We're fairly ubiquitous within the United States. I mean that in a good way. Most of your acute care or your inpatient hospitals will be using IMO content. And as we see some of the stats on the bottom there, we're touched by about 750,000 clinicians on a daily basis. We have about 98% of academic medical centers as well. The reason why that's important for this talk is not just us patting ourselves on the back, although we are pretty proud of this. It's because we do sit in a position that is probably very useful in helping institutions manage their HCCs. As you're going to hear from June, it's incredibly important to the not only clinical, excellence of an institution, but the financial health of an institution, that they really, really pay attention to these HCC diagnoses, particularly in a risk-based environment. Hence the term, hence the name of this webinar as Risky Business. It mainly has a financial impact when there are risk-based contracts, and HCCs go a long way in describing the acuity or the health of the patient population that you're trying to take care of. All righty. A few of the highlights bulleted on this screen, as you can see. I'll go back one more second, Jordan. I was remiss in not finishing a few of those bullet points. The last one especially, we're starting to deploy our NLP capability powered by some of our AI technology. That sounds very fancy. A lot of people are dropping words like, abbreviations like NLP and AI. What that means is IMO is hopefully moving towards a point where we can read blobs of unstructured text, such as op reports, HMPs, discharge summaries, and see if there are any HCCs that may be undocumented that are lurking in some of those areas. As I said, it's very important that we identify any condition that could be qualified as an HCC, and that technology that we're launching with our acquisition of MelaxTech really is going to be something exciting coming down in the future. Now we can go to the next slide, Jordan. Thanks. So where does all this terminology come from? For the most part, it was crowdsourced over 3 decades. We would take unstructured dictionaries. They may be filled with anything from free text to dumps of code sets, and that's all those dots at the bottom there, that bedrock that we gathered all of these data sources from, some from term requests, clinician entry, and I said new code sets that come into being. We capture all of that, and then we build that foundation. We build that foundation of interface terminology, terms that are curated, they're valid, they're relevant clinically, and they have the appropriate administrative, and standard code maps that follow along either silently or can be exposed to the end user. Once you have that middle layer, that foundation of interface terminology, that's when you're able to build all those cool skyscrapers. And those are just a few of the use cases. Obviously, some of them have been around for a while, such as decision support, capturing clinical intent, capturing diagnoses for billing. And then there's some of the newer ones, knowledge graphs, large language models, creating value sets. All of these things are more accurate when you have that very, very detailed foundation of clinical terminology. Okay, next slide, please. Where do we sit as far as why have we become this ubiquitous, this chosen language of clinical terminology? We are not trying to replace ICD or SNOMED. That is not our function. We recognize the need for both of those very, very important code sets, not only in this country, but around the world. But neither ICD nor SNOMED was created for the function of clinical documentation at the point of care. And that's a very important distinction. ICD-10, ICD in general, is really just a classification system, not really a true vocabulary. It's a bucketing system for billing. And so it's small and it's designed like a bucketing system. You have a disease for certain reasons or for another reason or for a reason I don't know. And that's ICD-10. SNOMED, while much more clinical and a true ontology, no question, really was designed for the collation of data and data for analytics. It is therefore meant to be post-coordinated, which is a fancy way of saying you take little blocks of terms and you group them together to create terms. SNOMED does have pre-coordinated terms as well, but there are holes for things such as laterality and staging. So you will not find a single term like stage 3 chronic kidney disease in SNOMED. You will find chronic kidney disease and you will modify it with the term stage 3. Very useful for analytics, not very useful if you're a physician trying to see 22 patients at lunchtime. IMO, on the other hand, in a typical load, we may have 3 to 4 times as many clinical concepts that we deliver. And we could also go into a much more fine detail. This is the key. IMO has the ability to go into very fine detail and apply multiple maps to a term that make it exactly representative of what the clinician was trying to say. So in this example, if I'm trying to say chromosomal alterations of group C and X, I can say that. But what about the fact that SNOMED doesn't have that term? That doesn't matter to IMO Health. We will create the term, we will map it to chromosomal abnormality, but that's as fine as you could get in SNOMED. So if you ever wanted to do a group study or go back and look at what that patient's exact condition was, IMO will have that exact term preserved. Next slide, please. So why is that important? It's important because if you take a term like breast cancer metastasized to pelvis, which any clinician would tell you in their mind is one clinical term, you'll see that it requires 3 SNOMED codes and 2 ICD codes. That's fine. That entire object on the left would be the term that we would deliver to our EHR partner for use. The clinicians probably only care about the breast cancer metastasized to pelvis description. All of those codes will be exposed based on the context. SNOMED for the problem list, ICD for billing. Those are just 2 examples. But you'll see you did require those 3 SNOMED codes. And as I said, very few clinicians know enough about SNOMED to understand that they have to find all 3 of those SNOMED codes. So what happens when you try to use something other than IMO to convert that to ICD using a crosswalk table? Well, you end up with a term, and this slide is actually labeled incorrectly. The preferred primary code is that top one, primary malignant neoplasm of the breast. And you pivot on that, and you end up with malignant neoplasm of unspecified site of unspecified female breast. Well, 3 very bad things happened using that crosswalk, not using IMO. You, ended up with a term that nobody speaks that language. You would never, I would argue, say to a patient, you have malignant neoplasm of unspecified site of unspecified female breast. You just wouldn't, that would be a nonsensical thing to say. Number 2 is you lost the information about metastases to the pelvis because that was contained in one of the non-preferred primary codes of SNOMED. And number 3, ICD is going to assume everybody with breast cancer is female. I get it. I understand why they do that, but it's not correct. So they've introduced a potential error. We know that somewhere around 1% of patients can be male in breast cancer, somewhere between 0.5% and 1%, depending on the study you look at. And so you cannot just assume female breast when you're documenting. If you look at the bottom right, though, when you use IMO to move data around, you not only move the description, that was the intent of the clinician at the time at the point of care, but that entire block of maps move with it. Okay, but someone's going to ask, well, what if the maps change? Well, then June and her team assign the new maps, and that object changes, but the clinical description does not. That stays, and that IMO identifier that you see in the middle near the bottom of the screen also never changes. Those maps are going to also change depending on where you are in the world. So if you're in the UK, they use a different version of ICD-10, or in Southeast Asia, or in Canada. That doesn't matter. We just change those maps that we deliver, but the term and the IMO identifier never change. So that term will mean the same thing in an Oracle Health system at Oxford in the UK, as it does in an Epic system in the Middle East, as it does in a Meditech system in Texas. Next slide, please. Healthcare has a data problem. Yes, you can Google that and you'll get 10,000 articles back. This is true. We had no data when we were in paper charts, right? It was all manually extracted, so we have very little data. We had basically billing data, but we didn't have clinical data. When meaningful use happened now coming up on, I don't know, somewhere around 15 years ago, I'm dating myself, we started gathering all this data, but not really collating it in a way that was always very useful. So you see all those tiles there on the right that are just kind of thrown together, and we had some free text and some clinical terms and some code-based systems, and we had different domains. We had some procedures and some problems and some labs, and it was really just a hodgepodge collection of data that wasn't being curated in a very, very useful way. There was no good dictionary to normalize all of this data against. So at the point of care, you ended up with terms that may not have been clinician friendly, an assortment of terms. Sometimes you just saw codes. I know in the ICD-9 days, I used to think in just, a few hundred codes that I had to memorize and go from there. And so it really did impact the point of care. But where the real problem was downstream. When you tried to do things like order sets or decision support or population health or clinical trials, having such a poor mound of data was really limiting. I refer to it as a data swamp, not even a data lake. Eventually, we got it to a data lake and then to a data warehouse. But when we first looked at it, before we had the ability to normalize this data, it was very, very messy. Next slide. So what IMO allows you to do is really clean that up. And what we do is that clinical description. What we did differently than others was we started with the clinical side of the equation. We said what is missing is a language for clinicians, the language that they were taught in medical school, nursing school, any of the various therapy schools that deal with patients at the point of care. And we said, let's start with their language. Okay, that's the hardest nut to crack. Let's figure out what they're trying to say. And then we're going to put that as the hub in the middle of the wheel. We're then again going to lean on June and her team of coders and mappers who understand the complex rules of all of those various codes that you see in dark gray and light gray around that hub. And we are going to individually, context-free, map those to that IMO description. That entire block that you see, the IMO purple description, the light and the dark gray codes, that's what gets delivered to our customers. So no longer do they have to worry about keeping those code sets up to date or managing them or worrying about changes or even understanding the rules of those code sets. That's our responsibility. We handle the updates and we keep that clinical term as the only thing the clinician needs to know to document on their patient. As you can see, obviously downstream, the effects are huge. Now you can do things like accurate clinical trials and value sets and defining groups that are meaningful. The term diabetes is not a very meaningful term when you're trying to do a study. Okay, you might want to do a study on type 2 diabetics with stage 3 chronic kidney disease. That's a useful term. So that's kind of what IMO does. We took that data mess and we're trying to clean it up get it from data swamp to data lake to data warehouse. Now it's usable. Next slide, please. Couple definitions before I turn it over to why we're really here today. Value-based care. This is not a new term. This has been talked about, I don't know, June 70s, probably going back that far. The idea, and it's a very noble idea, is that instead of just saying a clinician did a procedure, therefore we're going to pay them X amount of dollars for that procedure. In the olden days when I was a kid, they got paid whatever they billed. Later on, there was things such as PPOs and so on that discounted what you would get, but basically it was a fee-for-service environment. The idea of value-based care was, if we give you a sum of money to take care of a population of patients, you will get more reimbursement. You will have money left over if you take care of them in a way that not only provides the best value by keeping them healthy, but even when they do need to be treated, you do it in a way that provides the best value. So populations, early on, this was the world of the HMO. Another good idea in theory. In practice, the problem was populations varied in how sick they were. And so it was very difficult for some physicians to take care of a group of patients who were very sick when you're getting $11 per member per month. The new environment in value-based care is really the hallmark of it is understanding how sick these patients are. And this is the key to this discussion. So go to the next slide, please. So creating HCCs, which are collections of diagnoses, are really designed to understand how sick a single patient is, and therefore how sick your population of patients are, so that we can appropriately come up with an amount of money that will allow you to effectively take care of this group of patients. So if we read this definition, HCCs represent a classification system in healthcare that organizes diagnoses into related categories based on their severity and anticipated healthcare costs. That's the key sentence right there. For healthcare institutions operating under at-risk contracts, Medicare, being the front runner on some of those, but as they say, as Medicare goes, often the industry grows as well. It allows you to effectively manage those contracts and allows you to maintain financial health of the institution. So hopefully that provides a bit of understanding of who IMO is and why we are in a position to help with these. Those diagnoses that you see in the middle of that definition, those are IMO terms. And we map those to those appropriate ICD codes that help identify these HCCs. So hopefully that was enough of a background. I'm now going to turn it over to June, and June's going to talk about HCCs and specifically the changes that we're going through over the next, year or a few months.
Yep. Thank you, Dr. Rube. Let's take a closer look at HCCs by starting with their fundamental principles. I won't read each one, but as you can see on the slide, there are 10 principles that guided the creation of CMS HCC diagnostic classification system and the recalibration we saw with the change from version 24 to version 28. I wanted to highlight 2 principles: the prediction of medical expenditures, along with encouraging specific coding. The system is designed to predict future spending based upon today's condition. And by having the most specified ICD-10-CM codes to capture today's condition, this supports 2 fundamental principles. Keep these 2 principles in mind for later in the presentation. As people know, the recalibration of the system to be based upon ICD-10-CM codes created version 28. This shift caused substantive changes to the HCC categories and the specified ICD-10-CM codes within those categories. And on the next slide, we'll highlight some of those changes. Here you can see the number of HCCs increased to 115 with version 28 as compared to 86 in version 24. There is greater focus on chronic conditions within version 28. Severe persistent asthma is an example. It was not an HCC in version 24, but is now one in version 28. Even if a condition remained an HCC in version 28, the numeric identifier and the risk adjustment factor which reflects some severity, may have changed, as you can see here on the slide, for code Z68.42, the body mass index.
June, can I jump in for a second real quick?
By all means.
That risk adjustment factor is an important indicator. And what we're saying is if a patient was completely healthy, it's a multiplier, if you will, of how much money you receive. I can't tell you what that exactly is, but it is a multiplier. So a normal healthy person with no medical conditions would be thought of as a 1.000. As you add risk adjustment factors, this patient would be a 1.818. So it's additive to what their baseline state would be if they were healthy, and therefore multiplying the amount of money you would get in that risk adjustment payment. I just wanted to point that out, June. Thanks.
No, it's great. Thank you for that. Other changes include removal of certain conditions from the HCC classification, such as angina pectoris. And these changes highlight the complexity of the difference between the two versions and the importance of having systems in place to help manage the change. The need for coding specificity remains, just as we were talking about with the different risk adjustment factors and their addition cumulatives. Just as ICD-10-CM changes, so does the specific codes within those HCC categories. And we'll look at a few examples on the next slide. Here are new ICD-10-CM codes that were effective October 1st of 2024, which is the start of the government's new fiscal year. The codes on this slide reflect various pulmonary embolisms and were assigned to HCC 267, the deep vein thrombosis and pulmonary embolism in version 28. The next slide shows two additional clinical areas of ICD-10-CM coding changes. And as you can see, the new codes were added to identify different types of anorexia nervosa and were included in version 28. Our last example is the new class 3 obesity code. It is part of HCC version 28 with HCC 48. Of note, the other new obesity class codes are not considered HCCs. Each ICD-10-CM code update cycle may include changes to HCCs, as the conditions the new codes represent need to be considered for inclusion or even exclusion in the system. Along with specific ICD changes, CMS publishes proposed methodology changes known as an advanced announcement. So let's look at some of the topics in the calendar year 2026 advanced notice on the next slide. Keep in mind, this is the advance notice of the methodological changes. A final document is published typically the 1st of April, and it is titled Announcement. So let's look at some of the proposed changes. CMS can make quality bonus payments, or QBP, to Medicare Advantage organizations, or MAOs, that meet quality standards, which are measured under a 5-star quality rating system. And this is known as the star ratings. And CMS pays MAOs who have shown a 4-star or higher rating. The star ratings is designed to support CMS's goal of all programs to be patient-centric. In this notice, CMS is asking for comments on new measure concepts and methodological changes to inform future changes to the star ratings. The rulemaking process must be used for new measures and measures that have substantive specification changes. Even with the rulemaking process, the potential new or changed measures must remain a display measure on the display page for at least 2 years prior to becoming a star ratings measure. Display measures are published separately from the star ratings on CMS's website. The full list of star rating measures that will be used to calculate the quality bonus payment are listed in Table 4-1 in the advance notice. This table contains information about the measure type, weight, and measurement year. And while there are too many to list on a slide, I did want to highlight a few measures. There is one new measure being added, which is the kidney health evaluation for patients with diabetes, while 2 measures are returning after having substantive specification changes. Those 2 are improving or maintaining physical health and improving or maintaining mental health. This slide also shows 3 examples of measures that are being submitted for consideration to add to the star ratings program. On the next slide, we'll see what other quality initiatives CMS is undertaking. CMS is undertaking a national quality strategy. They continue to move towards a building block approach with the goal of streamlining quality measures across CMS quality and value-based care programs. This approach would allow for a set of universal or core sets of measures across their programs. To simplify and align the star rating measures with CMS's national quality strategy, they're looking to align the universal foundation measures and the star ratings where applicable. So the 3 universal foundation measures on the slide have been submitted to the pre-rulemaking measure review process to start the process for potential inclusion in the star ratings program. And on the next slide, we're going to look closer at the social needs screening and intervention measure. This measure captures the percentage of members who were screened using pre-specified instruments, at least once during the measurement period for unmet food, housing, and transportation needs, and received a corresponding intervention if they screened positive. The measure also identifies all types of pre-specified screening instruments for each of the different domains. While each domain has its own list of pre-specified screening tools, one tool, the Health-Related Social Needs, or the HRSN screening tool, is listed as an eligible screening instrument across all 3 areas: food, housing, and transportation. This measure is part of HEDIS, and the National Committee for Quality Assurance, or NCQA, is the measure steward, which means they are responsible for updates to the measure. And we will look next at some of their currently proposed changes from the steward. To help increase performance, NCQA is considering potential measure updates across all product lines to include G codes seen here on the slide, along with Z codes for identifying individuals with positive screening indicators. Currently, the screening indicators only allow for capture of link codes. And next, we're going to turn our attention to another important aspect of the HCC landscape: audit. The Medicare Advantage Risk Adjustment Data Validation Program, or most commonly known as the RADV audits. The RADV audits are used to verify the diagnosis reported for risk adjustment payments that they're supported in the documentation. Traditionally, these audits have been under the oversight of CMS, and CMS randomly selects a Medicare Advantage organization's contract to audit. The MAO would submit records, and CMS's findings were centered around the requested sample. With the 2023 final rule changes to the RAVD audits, there were major changes in the methodology, especially related to the findings. These changes include the determination of payment errors can now be extrapolated based upon a statistically valid method for the audit scope. The Office of Inspector General will play a larger role in the audit landscape, and audits may be more focused on areas that are at a higher risk for improper payment. CMS has published information on their Medicare Advantage Risk Adjustment Data Validation Program website, while the Office of Inspector General publishes information on their website. Here are 2 examples of OIG audit reports that will look closer at the findings on the next slide. The left-hand side of the screen shows the OIG's targeted reviews of high-risk group of diagnoses. For each organization audited, the OIG produces a report with a specific report number. There were over 20 different report numbers for this group of audits. Each report contains the details of the exact findings. Here is a high-level summary that acute stroke, acute heart attack, or a combination of acute stroke and acute heart attack were the most common diagnoses found to have codes not supported in the medical record documentation. The right-hand side of the screen reflects the OIG's findings related to questionable use of health risk assessments, which are connected to MAO's chart review. The Medicare Advantage organization companies may conduct chart reviews to ensure that the correct diagnoses are reported for risk adjustment. A health risk assessment can be used for early identification of health risks, and CMS has provided guidance to MAOs on the best practices related to these health risk assessments. It is allowable for MAOs to link the chart reviews to the records of the health risk assessment visits. This was an area of audit for the OIG, and you can see their findings on this slide. Positive screening conditions on the health risk assessment did not have additional documentation, such as a follow-up provider visit or additional testing to support the additional payments. The estimated financial impact, as seen here, is stated in the billions. So please refer to the Office of Inspector General's website for additional details. Next, we're going to look at some tips to prepare for these audits. As you can see, audits are part of the risk adjustment program. It's almost not if one will be audited, but when. So how can an organization prepare? Here are a few tips. Perform your own internal audit to assess alignment with program rules and regulations. This will highlight potential areas of concern. But periodically review internal compliance policies and procedures, as this will ensure they are up to date and the organization is following them. Follow industry standard documentation practices such as meet, monitor, evaluate, assess, or address, and treatment. Monitor the OIG and CMS's Medicare Risk Adjustment Data Validation Program to stay up to date on their latest news. Bringing this all together facilitates compliant practices which supports successful navigation of HCCs. And now that we have looked at the advance notice and the audit landscape, what does this mean for payers, providers, and ultimately patients? Collaboration is key. The need to communicate across payers, providers, and of course the patient facilitates the appropriate conditions are identified. This informs the model of expected medical expenditures of tomorrow. Starting with the assessment of an individual's risk, either for a health condition or a social need that influences health conditions, what processes are defined by both the payer and the provider organization to ensure the assessments occur? Are the organizations communicating their processes for alignment? What happens if positive indicator is identified by the payer? How does the payer support ensuring the patient or their beneficiary follows up on with a provider to address and or treat the positive screening indicator? Ensuring annual wellness visits occurs supports the overall goal of a patient-centric program with a personalized plan of service. Documentation of conditions identified in screenings, such as the SDOH or the health risk assessment, they do create that personalized plans of service. And again, documenting according to the industry standards at the highest level of specificity is key. And then how is this documentation shared where appropriate across the payer and provider? Another area of collaboration is claims processing. Denied claims create additional rework, and they're problematic as the conditions represented on the claim are not captured by the payer. So collaboration also supports that the payer and the provider are coordinated and the documentation is aligned to ensure all conditions that are reported for reimbursement comply with the program standards. And next, we'll look a little closer at the provider side. This slide shows a few areas to help successfully navigate HCCs. Again, documentation, diagnosis, their highest level of specificity. This will ensure you have captured the most appropriate code. Staying up to date with the ICD-10 CM code changes, as the system changes mainly happen in October, but they could happen in April. Staying up to date with those changes facilitates that the most appropriate and specific code is assigned. And that is one of the fundamental principles of the program. Remember the second fundamental principle that we spoke about earlier? The prediction of medical expenditures. Reporting all diagnoses at their highest level of specificity will provide CMS with the data for evaluation for future changes to the HCC model. This will ensure that CMS has the data and the cost information to perform their analysis for determining which of those diagnoses predict future expenditures and be added to the HCC program. Finally, leveraging technology using systems that support the HCC landscape within the current workflows facilitate the appropriate HCC capture and management. And now I'd like to turn the presentation back over to Dr. Rube.
Thanks, June. Next slide. So we talked about, how does this get integrated? No, you can go to the next slide. That's cool. How does this get integrated into the workflow? I do want to address one of the questions that came across, earlier. I saw a concern about a conflict between IMO applying ICD maps and what their clinical and medical coders apply. Couple answers to that. June and her team are medical coders. They are all certified, so they are exactly the same group of people as the people working in the institutions. On top of that, our content is routinely audited, and we work very closely with groups such as AHIMA to validate our code maps. We do attend coding clinics, and when there are conflicts, we have very open lines of communication. We will start by trying to resolve that conflict with the institution itself. And if there are still some discrepancies, we will approach groups such as AHIMA or coding clinics to try to work through those. So we are not applying these codes in a vacuum. They are not applied by doctors or people who don't understand these code sets. They are applied by professional certified coders and mappers who have tremendous experience in this field. So I appreciate the question, and thank you for allowing us to clarify that point. June, if you have more to say about that later, we could address that at the end. Did you have something you wanted to add to that?
Just really quick, I would add, if there's ever any questions around this, then we do have a support portal system and process. So for addressing.
That's right. So yeah, we're very open to discussions about anyone who has concerns about any of our code maps for any of our external vocabularies. All right, so what we have here is one example of an integration into an EHR where in the problem list itself, as we know, there are rules around HCCs. They must be addressed within a calendar year in order for them to continue to be considered valid diagnoses. Part of IMO's workflow around the problem list management has to do not only with creating clinically relevant categories such as advanced directives and coags and thromboembolic problems, as opposed to just a body system sort. You'll see there is a tab there that is an HCC list. We'll get to that in a moment. And what it allows you to do is very quickly, and you'll see right now we have V24/8 still indicated there. Eventually that will go away and you will end up with just the V28 and eventually hopefully not needing an indication at all when there's only one version. But we show you the differences between orange, which means it has not yet been addressed in this calendar year, versus blue. Now, blue can mean two things. Blue can mean that it's been addressed, or in this situation, like on the left, where the diabetes is blue, it's because there is another diabetes diagnosis right below it, which has a different HCC category, one that gives you a higher RAF score. By definition, we didn't assign that. It's just that's the patient diagnosis. So the appropriate HCC category would be that more acute one or more chronically ill HCC than just the generic diabetes, which does carry a RAF score, but at a lower one than that second diabetes, type 2 diabetes with diabetic neuropathy, than that would contain. So this is part of the way that we affect the workflow. We bring it right into the clinician's wheelhouse. Whether it's a hard step or not is really up to the institution themselves on how they deal with these alerts, but we do provide that, that indicator that there are these diagnoses that do need to be addressed. On the next slide, please. This is what that HCC list might look like. It's going to show you which ones are unaddressed. In orange, if it's in gray, it need not be addressed now. Either it's been addressed, or as I said, it's been superseded by a different HCC category that is more accurate for it to deal with. As I said, this is built into the workflow of the electronic health record application. So if you're using it, it's very intuitive. We have not had to train people on this. People seem to understand exactly what they need to do. Most EHRs have the ability to take a diagnosis from the problem list and move it over into the active problems, the active diagnoses that we're dealing with today. A physician may choose not to deal with it today and may say, let's bring you back in a week because this is too, complicated of a problem to deal with in that shorter period of time. But either way, it really does show you how important not only the EHR vendor, as well as the hospital institution, feel how important these HCCs are, that we developed a workflow solution that really inserts itself, hopefully not too obtrusively, into the clinician's workflow. Next slide, I think. Yes. So that was it. That was what I had. I just wanted to show you how this fits in practically into the real world for clinicians. The feedback so far on that part of the workflow and the problem list management in general has been very, very positive. So we're very excited about it. Now, that being said, we do have open lines of communications for feedback. We've gotten tremendous advice on how to improve the product, and some of those, we can't take into account, some we do. But hopefully it's all to move the product ahead. We understand the burden on the healthcare teams, and we do not want to complicate their workflow just for the sake of complicating it. However, these HCCs are incredibly important, as we pointed out over and over, to the financial health of an institution. Therefore, we are trying to design a workflow solution that both solves that problem without being unduly burdensome on the healthcare teams. And with that, we'll open it up to see what other questions that we have.
All right. Thank you, Steve and June. Yeah, so if you have any questions, type them into the Q&A box. We definitely have a few, and I apologize if I butcher anything in them. So bear with me in these questions. All right, so will you include the HCC tag for HHS-HCC diagnosis as well, or just CMS? I don't know if that's a question for you, Dr. Rube, or
that's all June.
Okay.
Yeah. Yes. We do have the ability for the information for multiple, because as you can see, there are multiple HCC programs, one being for HHS, to include, and how those are surfaced then becomes a matter of how your system would look to view those. So if there's additional details needed around the HHS HCCs, please reach out to the email here and to contact us, and we can have further conversations.
All right. One concern is that medical coders are bound to the rules and guidelines of ICD-10.
So Jordan, I answered that. I answered the next two.
Oh, you did? Oh,
yeah,
right.
Those next two are answered already.
Okay. Are risk scores for patient visits in 2025 a blended version 28 and version 24 model, or is it 100% version 28?
Yeah, this is where the difference between a visit year / calendar year payment year, because the system is meant to predict future expenditures, is so while there has been a blended model from moving from version 24 to version 28, the actual visits that are happening now are impacting the payment years ahead, the years ahead. So while there's still in some ways a blended as far as payment for the year, what the next year is going to be 100% version 28. So realistically, the visits that are occurring are impacting that 100%.
June, do you see that question by Kaylee?
I did around the class 3, and this is where I will have to verify, because CMS publishes for HCCs 2 different types of files to indicate codes that are part in which actual HCC part of the program. They have a file like the initial mapping, and then they have a final mapping. And the reason for that is because of the code updates that occur in October, because HCCs run on calendar years, but our code updates run from October to October. So there is times that that they need to run the analysis for these new codes and these new conditions to see, are they aligned and do they fit within the HCC? And so I will double check, but what I saw for that final year identified in HCC for those classes codes, at least for the morbid one. So we can, verify that. Is there a future plan to allow for the identification of ECQM when hospital is doing the updated matching? I'm not sure who asked that question, but if there's some additional context around that, that would be great that they could include for their question.
Yeah, I'll just say in the past, the ECQM workflow, we've been involved with that. It's mainly a function of electronic health record on how that is handled. What IMO can do is we can look at the content and see which of those terms are needed or available. But we would probably need a bit more context to answer that question more accurately.
Okay. How soon do organizations typically see measurable results with the IMO Health Solutions supporting with HCC management?
So I could start that one. Usually fairly quickly, usually within the first several months. And the feedback that we've had is that many clinicians are just not aware of this. And I can say that as someone who's practiced family medicine for almost 20 years, it's not something that would have been on my radar. I'm concerned about patient care and taking care of the patient and making sure I deliver the medicine as well as I can. I do understand the importance of documentation, but something as fine into the financial and billing weeds as HCCs is not probably front of mind on most clinicians who are trying to get through a very busy day. By putting it in a simple, we think, workflow ad around the problem list and bringing it to the attention and educating medical staffs on the importance of these, we do see increases in HCC capture very, very quickly, and we do have data supporting that.
Cool. All right, so what steps should organizations take now to kind of prepare for the upcoming changes?
You want to start, Dr. Rube? Or
yeah,
okay.
I mean, as I said at the beginning, and this is a statistical fact, because most hospitals already have IMO, we are already taking those measures, as you saw from that workflow slide that showed that we're already showing the blended model. As with the transition from ICD-9 to ICD-10, when using IMO content, that is one of the values we provide. We take care of these transitions as seamlessly as possible. What I would say to an institution is about, again, education. I'm sure most of the administrative departments, the coding and billing departments are very aware of this, but making the clinical staff aware of this as well is probably important, at least so they understand what they're looking at on the screen if we're going to make it visible in their workflow. However, the actual transition and the changing of the codes and the groups, that's on us to take care of, and we do that as seamlessly as possible. Again, with those open communication lines when people have questions about what's going on.
I would agree. And yes, I think education is key. Just to add to everything Dr. Rube said.
Okay. Says, do you work within the Epic system? Yes. Right?
Yes, we are actually, it's more than just work with Epic. We have been partners with Epic for going on 20 years at this point, and we are considered foundational, which people familiar with Epic understand the power of that word being part of their foundation system. Our problem content, our interface terminology is part of the Epic foundation system. Some of the workflow features that IMO have, that's something that needs to be discussed as an add-on. But yes, we are fully integrated into not only Epic, but Meditech, Oracle Health, Athena, ECW, NextGen. If you're international, InterSystems, and I'm sure I've left out many because many of the smaller EHRs as well, such as ModMed and so on. But yes, our goal when we partner with an EHR is to always be fully integrated so that there is little to no training and it's seamless operation. You are not going to an external site to access IMO data. So if you knew how to use Epic yesterday without IMO, you know how to use it tomorrow with IMO.
Awesome. Can the IMO alert providers to readdress HCC conditions twice a year, while CMS only requires it to be addressed once a year, documenting once between January 1st and June 30th, and again, July 1st to December 31st, contributes to a more consistent revenue cycle?
Sure. That sounds like an ex-CMO asking that question. Alerts, the answer is yeah. It's not IMO who would do that. The answer is yes. That is a function of the application, the EHR application that you're using. Most of them have very sophisticated alert systems. You should always take into account what we call pop-up fatigue. Are these going to be hard stops, soft stops, pop-ups? You got to keep a happy medical staff. So the ability to alert people always needs to be weighed against, should I alert people all the time? But as far as I have seen, again, this is not IMO functionality. We are mostly content with some workflow. The alerts are really handled by the institutions themselves.
Okay. Does your product help eliminate the duplication of conditions that are the same but worded differently? Example is diabetes and type 2 diabetes.
So can you go back, I think, 2 slides? One more. Yeah, there. So if you look on the right side of the screen, it's almost like we planted this question. We do have the ability to provide cleanup functionality basically around 3 different items, not just what you said. If you look there where it says duplicate group, duplicate, where's the Lou Gehrig's? Oh, it's not on here. But terms like Lou Gehrig's disease and ALS are exactly the same thing. We could clean that up. We have the ability to clean up expired problems, so you shouldn't be pregnant for 3 years. And we have the ability to clean up terms that are at different levels of specificity or terms that have evolved over time. So you can't have, stage 2 and stage 4 chronic kidney disease at the same time. Certain masses become cancers. They evolve over time. So yes, we have the ability to make recommendations on cleanup, but it is always the final word of the clinician who will have to accept or reject those change recommendations.
All right. I think we've reached our end of Q&A. So thank you, Dr. Rube. Thank you, June. We're going to go ahead and close out. I hope you found everything useful in today's webinar. Be on the lookout for that certificate of attendance and also the recording. If you have any questions regarding, technical support or content questions, contact our customer support at customersupport@imohealth.com. And if you have any questions regarding our solutions, please contact sales@imohealth.com. Thank you so much for attending, and I hope you have a great rest of your day.
Take care.